I'm Dr. James Harlow, physician, researcher, and the person who's going to tell you what most doctors don't have time to say. On this channel, we cover the chronic conditions quietly destroying American health: inflammation, metabolic disease, hormonal collapse, and the lifestyle patterns driving them. No supplements to sell, no agenda. Just the science, peer-reviewed, verified, and delivered straight. I want you to think about the last time you felt completely healthy. No chest pain, no shortness of breath, energy levels normal, blood pressure fine. Your doctor looked at your numbers and said, "You're doing great." Now I want to tell you something that most physicians will not say in a 12-minute appointment. That feeling of being fine, it means nothing, because the deadliest biological process in modern medicine produces no symptoms whatsoever in its early stages. It is called chronic low-grade inflammation. And right now, in millions of Americans who consider themselves healthy, it is silently damaging arteries, corrupting insulin signals, and accelerating cellular aging at the molecular level. Here is the part that should make you stop scrolling. This is not a theory. This is not alternative medicine. A 2023 collaborative analysis published in the Lancet, covering over 31,000 patients across 3 major randomized trials, confirmed that inflammation, measured by a simple blood marker called hs-CRP, was a stronger predictor of cardiovascular death than LDL cholesterol in patients already receiving statin therapy. Let that land. The number your doctor monitors most closely, your cholesterol, is less predictive of whether you will have a heart attack than a test most doctors never order. I'm going to show you exactly why. And more importantly, I'm going to show you what the peer-reviewed evidence says you can do about it. Let me teach you the biology first, because once you understand the mechanism, everything else becomes clear. Your immune system has 2 modes. Mode 1, acute inflammation. You cut your hand, a virus enters your body. Your immune system activates, sends white blood cells, releases chemical signals called cytokines, clears the threat, and shuts down. This is healthy. This keeps you alive. Mode 2 is the problem. Chronic low-grade inflammation is when that immune activation never fully shuts off. Your body stays in a permanent state of low-level alert, not because of an infection, but because of sustained biological stresses that your body interprets as a continuous threat. The primary stressors, documented across peer-reviewed literature, are these: visceral fat, the fat stored around your abdominal organs, not under your skin; ultra-processed food consumption, particularly refined oils and added sugars; chronic psychological stress, which drives persistent elevation of the hormone cortisol; inadequate or fragmented sleep; and physical inactivity. Each of these activates a molecular switch inside your cells called NF-κB, nuclear factor kappa B. This is your master inflammation switch. When NF-κB is chronically activated, it instructs your immune cells to keep producing 3 key inflammatory molecules: IL-6, TNF-alpha, and C-reactive protein, or CRP. These molecules were designed for emergencies. In chronic circulation, they become destructive. And here is the critical point. They circulate silently. You feel nothing. But the damage accumulates daily, across every organ system. Let me walk you through what this looks like inside your body, starting with your cardiovascular system, because this is where the evidence is most unambiguous. Your arteries are lined with a single-cell thick layer called the endothelium. Think of it as an extremely fine inner skin. When inflammatory cytokines, particularly IL-6 and CRP, circulate chronically, they damage this lining. The endothelium becomes permeable. Oxidized LDL particles penetrate the arterial wall. The immune system responds by sending macrophages to clean up. Those macrophages become engulfed by fat and turn into what are called foam cells. Foam cells accumulate, plaque forms. The artery narrows. This is atherosclerosis. And it does not start because you had too much cholesterol. It starts because your arterial wall was inflamed and vulnerable. The Lancet analysis I cited earlier, 31,245 patients across the prominent, reduce-it, and strength trials, found that patients in the highest quartile of hs-CRP had a 31% higher rate of major cardiovascular events and a 168% higher rate of cardiovascular death compared to those in the lowest quartile. Meanwhile, LDL cholesterol showed no statistically significant association with major cardiovascular events in patients already on statins. A separate meta-analysis published in Frontiers in Cardiovascular Medicine, analyzing data across 160,309 patients, confirmed that elevated CRP, IL-6, and fibrinogen are each independently associated with significantly increased cardiovascular disease risk. Here is the clinical reality. You can have a normal LDL. You can be on a statin. And if your hs-CRP is chronically elevated, your cardiovascular risk remains high, and no one is treating it. Now let me show you the second system being destroyed. Type 2 diabetes does not begin on the day you receive a diagnosis. It begins years earlier, with insulin resistance, and chronic inflammation is one of the primary mechanisms driving that resistance. Here is the mechanism, documented in Nature Medicine and confirmed across decades of research. TNF-alpha directly interferes with the insulin receptor signaling pathway at the cellular level. When TNF-alpha binds to cells, it activates serine kinases that phosphorylate, essentially jam, the insulin receptor substrate. The cell stops responding normally to insulin. Glucose cannot enter efficiently. Blood sugar rises. The pancreas compensates by producing more insulin. This cycle of compensation eventually leads to beta cell exhaustion and clinical diabetes. The research published in MDPI Cells in 2024, reviewing data from over 500,000 adults, found that individuals with pre-existing chronic inflammatory conditions had a significantly higher risk of developing type 2 diabetes, and that elevated hs-CRP and IL-6 were measurable predictors of T2D before clinical diagnosis. Inflammation does not accompany diabetes in these cases. It precedes it. This is not a detail. This is a window of intervention that currently goes almost entirely unused. Now I need to tell you something about the system designed to catch this, and why it routinely fails to do so. hs-CRP is not expensive. It is not experimental. The American Heart Association and the CDC issued joint guidelines recognizing hs-CRP as a clinically relevant cardiovascular risk marker. The test is available at any standard laboratory, and yet it is not part of a standard annual physical. I am not going to tell you why that is. I am going to tell you what the peer-reviewed evidence says works to reduce it. A 2025 meta-analysis published in Nutrition Reviews, analyzing 33 randomized controlled trials covering 3,476 participants, found that the Mediterranean dietary pattern produced statistically significant reductions in hs-CRP and IL-6 compared to control diets. A broader umbrella review in the British Journal of Nutrition, covering 27 meta-analyses, identified the Mediterranean diet as producing the most significant reduction in circulating CRP of any dietary pattern studied, a mean reduction of 0.61 mmol, with RCT-only data showing reductions up to 0.71 mg. The mechanism is direct. Polyphenols in olive oil, vegetables, and legumes inhibit NF-κB activation. The omega-3 fatty acids, found in fatty fish and walnuts, compete with and displace pro-inflammatory omega-6 pathways. Refined seed oils and ultra-processed foods do the opposite. They drive NF-κB activity and sustain the inflammatory state. This is not a wellness recommendation. This is the randomized controlled trial literature. Here is what I want you to leave this video knowing. Chronic inflammation is measurable. It has a biomarker, hs-CRP. It has documented causal roles in cardiovascular disease, insulin resistance, and type 2 diabetes. And it responds to specific evidence-based interventions that are accessible to anyone. At your next physician visit, ask for an hs-CRP test, not a regular CRP. A high-sensitivity CRP, normal is below 1.0 mg/L. Elevated cardiovascular risk begins at 3.0 mg/L. If your number is above 1.0, you have actionable information, and now you have the scientific framework to act on it. The evidence is clear. The intervention is available. The only missing variable is whether you have the information to demand the right test. Now you do. This is the medical truth.